Good morning. So this morning we are doing something a little bit different. We're going to do back-to-back plenaries together. So Byron Powell will go first, and then we'll take questions. And then Lisa Saldana will go following Byron, and we'll also take questions. And so we're trying to pull in two amazing implementation scientists in a short period of time here together. So I'm going to introduce them each separately. So introducing Byron. Byron's a professor in the Department of Health Policy and Management here at UNC at the Gilling School of Global Public Health. His research focuses on efforts to improve health, behavioral health, and social services. Byron is really just an amazing contributor to the science of implementation and looking at kind of the contextual barriers and facilitators to using evidence in practice. He's also done enormous work around identifying implementation strategies and how it is that implementation strategies need to be tailored for certain conditions and contexts to be effective in supporting the use of different interventions and services. And so we are so pleased to welcome Byron right now. Thanks.
Thank you, Allison, and thank you all for being here bright and early on this Wednesday. It's a real honor to be here, and it was a privilege to present last year, and really thrilled to have an opportunity to come back. But I must start by saying that I tried to get Allison to let me skip this talk 3 times, and she's very persistent. And the reason I did is because I claim no real expertise at the intersection of equity and stakeholder engagement. I'm very much a learner in this space, and so my plan today is to sort of share some work in progress and some work that we've done at the intersection of implementation strategies and mental health services research. But hopefully I can keep learning. My other plan was to have Amber Haley give this talk, but she is actually in Little Rock, Arkansas at a implementation facilitation training. So to the question actually this morning, in addition to our efforts here, there are other efforts to build capacity in the field for implementation practitioners. So happy to chat with you all about that if you have questions. But the reason why I wanted to pawn this talk off on Amber, who's my first ever PhD student, and really have just been tremendously blessed to work with Amber. She has a really rich background in stakeholder engagement. Before she came here, she was doing a lot of community engaged research in Richmond, Virginia, and was the associate director of community engagement for the Virginia Commonwealth University's CTSA. And so I've learned a ton from her, and much of this work is informed by Amber. So kudos to her. And like Leo and everyone else yesterday, I think this is really teamwork. And so just want to acknowledge funding, collaborators, and hopefully I'll do that throughout. I know I have just a quick time, but try to mention folks by name as they come out. This is all really collaborative work, so try to do that. And just to give you a quick overview, so I'm going to give an introduction to implementation strategies. Some of that might be review from last year if you were here last year. And then I'm going to share a bit about a project that we are doing to help organizations tailor implementation strategies to their settings and how we're trying to think about stakeholder engagement within that context. And then share some of our additional opportunities for stakeholder engagement that we're trying to incorporate into our work, and hopefully have some time for discussion. So to start off with, we've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, or scale up of effective interventions. And so Leo talked a little bit about this yesterday, and others as well. But these are essentially the interventions for our interventions, or the how, right? How we're getting these effective practices into routine care. I often quote Carolyn Clancy, who's with the Department of Veterans Affairs, who says that really implementation is about making the right thing to do the easy thing to do. So hopefully we're trying to equip individuals, organizations, systems with the tools that they need to innovate and exnovate and really deliver quality care. So some of our work in the field has been to develop a compilation of implementation strategies. And the idea here is that we need a language for the basic building blocks of implementation, the interventions that we can use to get these effective practices into routine care. So in 2012, we published this compilation of 68 discrete implementation strategies. And this was really based on a integrative review of the literature with a multidisciplinary team, but these strategies weren't necessarily vetted by experts in implementation, research, or practice. And so we had an opportunity to actually refine this compilation with colleagues from the VA and elsewhere, where we actually presented these terms and definitions of implementation strategies in a multi-round Delphi process and through an exercise called concept mapping. It basically got them to suggest what are we missing, what strategies need to be added to this compilation, and do these terms and definitions make sense moving forward, basically vetting this and validating this in a certain way. And so these are, I'm not going to spend a lot of time talking about these, but again, we think of these as building blocks for multifaceted and multi-level implementation strategies. Hopefully these compilations can be useful as you're considering implementation strategies in your context, whether that be through research or more applied practice efforts. And hopefully this presents a little bit of common terminology and language for the field. The field of implementation science has often been referred to as a Tower of Babel, where we have all these terms and definitions and frameworks and everyone's talking past each other. And we certainly didn't solve the Tower of Babel problem with this compilation, but we tried to at least present one reference where we could have a common reference point there. And we've been really pleased to see this compilation and this work be picked up at least in the US and the federal level through program announcements and the like through NIH and the VA, and perhaps in a more applied way through PCORI and SAMHSA and others. But even more pleased to see colleagues extending this work and really trying to say, okay, we have this list of implementation strategies. Do these strategies make sense to people that are working in more applied contexts? So Clay Cook, Aaron Lyon, and colleagues, we just published a paper in Prevention Science and another in Press in the Journal of School Psychology, where we basically engaged school administrators and other educators to say, do these strategies make sense within an educational setting? How do they need to be refined for that setting? And what is the sort of feasibility and importance of these strategies for that sector? Allison and Annette Boas and I are working with funding from the William T. Grant Foundation to see how do these apply to a technical assistance environment within child welfare. And similarly, Prerna Martin, who's at the University of Washington, is working to see how do these strategies apply in low and middle income countries. These fly there. They need to be refined and updated for those settings. So really, really pleased to see this applied in a more concrete manner. And just to provide a quick example of what we're kind of going for with implementation strategies, and maybe this is intuitive and old news for you all, but the idea oftentimes in implementation is that we're identifying potentially barriers and facilitators, and we're actually addressing them head on with implementation strategies, right? So if we have barriers related to lack of knowledge, it might be that some sort of educational, interactive educational session is appropriate. If there's a perception reality mismatch, so for instance, if we have clinicians, organization systems that say, hey, we're already delivering evidence-based practices with fidelity, it might be that administering fidelity measures and feeding that back to clinicians in comparison to their peers could be an effective strategy. If there's a lack of motivation, we might want to consider some sort of incentive or sanction or other strategies. And similarly, if there are issues with beliefs and attitudes, one example would be to influence peers through an opinion leader implementation strategy. The idea is that we want to have a tight fit between the actual problems and barriers that we're facing and the solutions that we're using. To give a more multi-level example, so oftentimes we know that we have a myriad of barriers, right? It's not just a couple problems. That a lot of times we're working in very complex systems, and there are a lot of challenges to implementation. And so more often than not, we're using multi-level or at least multifaceted strategies. And so this is an example from Brian Weiner's work who published a paper in 2012 talking about 5 different ways to think about multi-level strategies. This is just one. So you could think about something like a healthcare collaborative that operates at an organizational level, and other strategies to address provider communication, improve provider communication that would actually impact, something like physicians' motivation. And similarly, you could think about education and counseling for women to improve women's knowledge about cervical cancer screening. Both of those things hopefully would improve patient-provider interaction and ultimately increase cancer screening rates. So this is just one example. The idea is that we want to be thoughtful about the strategies that we're using and combining them in systematic ways. How many people think we do that routinely? Crickets. All right. This is too smart of a group. So we talked about some of these things, I think, that are sort of more frequently used in the field. One is the train and hope or train and pray approach, right? We send people to a lot of trainings and we hope that their behavior changes. And I think that's, we know that that's necessary but not sufficient in the field. We also use sometimes kitchen sink approaches, and this is perhaps too pejorative. I think we're limited by our evidence and our current body of knowledge in the field. But essentially, we might be using multifaceted strategies that don't necessarily, we're really just trying to use an intensive strategy without maybe a great rationale for why we're using each component strategy or discrete strategy. And there's actually evidence in the field to suggest that multifaceted strategies are not always more effective than single component strategies, which is a little bit goofy given that we know we face a myriad of barriers and we often need a lot of strategies in practical settings. But again, the rationale for the use of component strategies is not always great. So this is debatable, and I'd be interested to hear everyone's thoughts. I mean, the extent to which implementation strategies need to be tailored to different sites, systems, organizations, whatever your level of tailoring needs to be. Do they need to be tailored, or can we use more one-size-fits-all strategies that are flexible enough and adaptive enough to be effective? And there's a lot of ongoing work in the field to answer those kinds of questions, and honestly, the evidence has been a bit equivocal on that notion. And then this is my personal favorite from Martin Eccles, who said, oftentimes as we're thinking about implementation, we use the Islagiat principle, right? It seemed like a good idea at the time. And I think that's, again, with full admission of the limitations of our evidence and theories in implementation science, it's not always clear-cut what we should do. Just a couple examples of how these approaches have led to missing the mark. So one is from a study of children's social service settings, in which we examined basically what we considered implementation best practices, and I'm putting that in quotes, again, given the limitations of our evidence. But what we found is that in implementation as usual in these settings, implementation was not typically driven by theory, evidence, or these best practices. And we also saw that a lot of times implementation strategies weren't necessarily used with the frequency, intensity, or fidelity needed. So the example that I often give is clinical supervision in mental health, right? So we would ask organizational leaders whether they were providing clinical supervision. Of course, they said, yeah, we routinely provide supervision. Then when you asked clinicians whether they receive supervision, they would say, actually, we don't receive it, or we receive it infrequently. When we do receive it, it focuses on administrative things like, did you get your paperwork on time? Are you billing appropriately? And essentially not focusing on enhancing clinical skill and those factors that if we consider best practices within supervision or gold standard supervision, that wasn't necessarily being provided. Another example, which to me is really interesting, this is from a study where they looked at 20 different efforts to systematically tailor implementation strategies. So these were like specific research efforts where they were looking to assess barriers and then respond with appropriate strategies. And even in those cases, they found that there was often a mismatch between the strategies or the barriers identified and the strategies used. So for instance, they might identify organizational systemic issues, but then respond with more provider training or more knowledge-based strategies. And so this suggests that we really have a lot of work to do with respect to implementation strategies, and particularly enhancing the effectiveness of implementation strategies. And I'm not going to go into detail on these 5 points, but I'm going to talk a little bit about our efforts to enhance methods for designing and tailoring implementation strategies, but also just to suggest that some other priorities with respect to implementation strategies in the field. So Leo mentioned yesterday the idea of testing mechanisms, or how and why these implementation strategies actually work, and understanding that. And I think you were expressing, Leo, it may be premature to do that before we have many trials of implementation strategies. But certainly we want to start thinking early and often about how and why these implementation strategies work, what our rationale is for using them, and sort of drawing upon the best of our theory and evidence and examining that. We certainly need a lot more effectiveness research and implementation science, and comparing different implementation strategies empirically. There's a lot of descriptive work, but really comparing both discrete, multifaceted, and tailored approaches, as well as really testing these different methods for selecting and tailoring implementation strategies. And this fifth point might be the geekiest yet, but I think it's something that I believe strongly in. I don't think we do a good job of tracking implementation strategies. And so we've worked a little bit to start developing methods for tracking. So basically this is like, how did we get from point A to point B? If you're in a large scale implementation effort, how are you really documenting? And you might say, hey, we're providing facilitation or coaching. How are you documenting that? What other strategies are you using? And how do we do that in ways that are pragmatic and feasible for stakeholders? So these are just some priorities that we're trying to address in our work. And actually, I was looking at this paper, and I started to search for words like partnership and collaboration, and I was really disappointed in our effort there. But I think that each of these are inherently priorities that obviously need to be built on partnerships with a wide range of stakeholders, and will be enhanced by that. And so I think we can think through some of the implications of that. So we've worked a little bit to identify some potentially more systematic methods for applying implementation strategies, and others in the field. Heather Cahoon from University of Toronto has a nice systematic review in this area, identifying 15 what you would call replicable methods for this. And we're just starting to test and apply some of these methods in various settings. And so I'm transitioning now into a study that's funded by the National Institute of Mental Health. And this is through the K mechanism, which is a career development award for those of you who might not be familiar with that. And this is a really nice opportunity to get both experience conducting a research study in a mentored context, but also to pursue training in various areas. So this is an area, for instance, where I'm getting extra training and support around community engaged research, and having really nice opportunities to learn in those spaces. And the idea here, and what we're calling the collaborative organizational approach for selecting and tailoring implementation strategies, is that organizations need support to think through what strategies they're using and to tailor them to their settings. And I'll talk more about that. But this study is basically involving the development and pilot test of that COAST-IS intervention. So it's going to be tested in a randomized matched pair design here in North Carolina with the North Carolina Child Treatment Program, which I'll say a bit more about in a second. And just in terms of the guiding rationale, why are we developing a new intervention? So first is just this acknowledgement that we face multi-level barriers to implementation, and that organizations might have very different barriers, right? As we think about it, again, this whole study is banking on the notion that we don't need one-size-fits-all approaches. We actually need more tailored approaches that are contextually delivered and sensitive to different contexts. It's also, I think, motivated by the notion that organizations and systems are implementing a lot of different practices, whether they're evidence-based practices or other types of psychosocial practices, or really just a wide range of interventions. And this can obviously be overwhelming. People can have sort of innovation fatigue. We always think that our thing is the most important and should be put on the front burner, but they're doing a lot of things, and thus I think we really need to build capacity in organizations and systems to innovate and excavate, right? To stop doing what isn't working, and to really implement systematically practices that they want to prioritize. And so part of COAST-IS is really trying to build this capacity and to give them an approach that could be used across interventions. So in this case, we're actually using Coast IS to implement trauma-focused cognitive behavioral therapy in North Carolina, but we hope that this could be applicable to a number of other approaches. So Leo showed a version of this model. This is kind of a Frankenstein model of multiple conceptual models in the field. So this just notes that the evidence-based practice we're implementing is trauma-focused CBT. We're trying to develop and pilot this approach, the Coast IS approach, which is really our method for selecting and tailoring strategies. And again, this is going to lead to, hopefully, more systematic selection of implementation strategies. So when we think about our compilation of strategies and other approaches that we could use, how do we actually select and choose those and design them so that they will be appropriate for organizations? And ultimately, this is hopefully helping organizations to address multi-level barriers. And in this pilot, we're looking at implementation outcomes both for TFCBT, so looking at fidelity of TFCBT, and then looking at things like how acceptable, feasible, and appropriate is Coast IS. Can we actually do this on a larger scale? And how can we actually refine the intervention? So the stakeholder engagement partnership approach, I should have had a slide in there with sort of the continuum of engagement. But this has been sort of an ongoing, evolving process. So originally, we partnered with the National Child Traumatic Stress Network and folks at Duke University here. And we're going to pilot this in that context. They also are very much involved with the North Carolina Child Treatment Program, which is a statewide effort to disseminate and implement trauma-focused treatments. And so both of those organizations have partnered closely with us to really inform the development and the methods that we're using within the pilot study for Coast IS. And we originally in the grant proposal proposed to work with an organizational advisory board, so clinicians and leaders in the community who had implemented trauma-focused CBT and other interventions, and who would have a sense of whether this would be feasible and how we could refine the intervention before we pilot it. Again, the K is a nice learning opportunity. So a couple of my K mentors said, "Hey, dummy, how about partnering with youth and caregivers? You know, might they have something to say about the types of things that you need to be addressing in these settings?" Of course. So we had the opportunity to partner with those groups as well, and I'll share just a bit about each of these groups. So again, the North Carolina Child Treatment Program has been really tremendous. So this is Lisa Maya Jackson and Millicent Blythe and Beverly Glinke in particular have been really helpful and heavily involved in our efforts. Very generous partners, much like Amber. I couldn't have fared better with my sort of first foray into community engaged research with these partners. They've been tremendous. And then the folks at the National Child Traumatic Stress Network, which includes Lisa Maya Jackson, Trip Ake, and others, have been great. So these groups have been sort of, in a way, gatekeepers to these communities. They've been, at least for NCCTP, they've really been full partners in terms of informing the design, data collection and analysis. And NCTSN has also helped connect us to the caregiver and youth advisory groups. The organizational advisory board was comprised of 10 of these clinicians and leaders, and they met with us for, I think we had 4 2-hour meetings, along with sort of some communication and back and forth in between, where we're really trying to think through what the intervention looks like, what's the timing and pacing of the intervention, what kind of language makes sense, and really can we speak the same language when we're talking about implementation related concepts. And ultimately, is this going to be a feasible and an acceptable intervention? Lisa, I'm going to save you at least 2 minutes to talk. Don't worry. I'll try to hurry up. So the youth and caregiver advisory boards. And let me rewind back to the "hey dummy" comment. So one of the things that we were really struggling with in this is like who our stakeholders are and who needs to inform this, and which ways, how do they need to be involved? Not wanting to, involve people in a tokenistic manner, wanting to have really clear purposes for why we were talking to folks and engaging them and taking their time. And so for the youth and caregiver advisory boards, we're developing an organizational level intervention. So my original thought was we don't actually need to, they're not necessarily the primary stakeholders. But the way that we ended up working with them is really to try to understand what are the barriers and facilitators to trauma-focused CBT and other trauma-focused interventions, and really trying to share sort of the broad intent of our intervention and how they can speak to those factors. And so we engaged both young adults who were former recipients of trauma-focused interventions, and then caregivers who had been through this. And I think for me, it was a pleasant surprise. I'm really glad I was pushed in that direction. And I think it will enrich work going forward, and already finding ways to engage these groups in other projects. So it's nice to see the relationships develop and hopefully be able to maintain those over time. So in terms of potential impacts for our project, we're hoping that this leads to again, a better understanding of client and organizational level barriers and facilitators to implementation. Certainly has informed the timing, pacing, and coordination of the Coast-IS intervention. I wish we could have hit more on this, but really focused on the materials that we're developing. Do these make sense? Does this language make sense? Does the format of these sort of intervention materials make sense? And I think if I've learned anything, is that this takes a lot of time, and wish I had more time to do that work. They've also informed our measurement approach and the types of measures that they actually would find useful on an ongoing basis within their organization, which I thought was really helpful. And certainly these organizations and partners will be really helpful as we try to think about testing this on a wider scale and potentially scaling up this intervention as it's appropriate. And our approach has been to share all of our intervention materials and to hopefully, our commitment is to make these available. And if anything ends up worth a darn from any of these, from any of this pilot, we really want to share this and make this freely available to the NCTSN, the North Carolina Child Treatment Program, and other stakeholders. So I know I'm probably have 5 minutes or so. Just wanted to share a couple of other additional opportunities I think that we have for engaging stakeholders more in our work and the ways that we're thinking about that. And one is actually was brought up a number of times yesterday, that we often think about readiness from the perspective of organizations and systems, and not necessarily from the perspective of researchers. And Chris Shea is a colleague in health policy and management here at UNC. We've worked to develop some initial competencies and a framework around readiness for community engaged dissemination and implementation. And Chris is taking that forward. Actually, Amber is also involved in trying to develop a measure of this. And I think this connects to the work that Paul was sharing. So Paul, I'm eager to kind of to connect you and to see what the overlap is between your assessment and this work, and whether there might be opportunities for collaboration there. But again, I think the intent of this was to say, this is a little bit more university focused, and to say like, hey, we need to get our stuff in line, see if we're ready, and if we're not, can we build some infrastructure to train people and to support them in conducting this. Another area that was brought up yesterday is the idea of, are measures feasible, appropriate, pragmatic for our settings? And we have a lot of issues with both basically weak measurement approaches in implementation science, and measures that might be psychometrically strong but are not at all pragmatic. So for instance, they might have way too many items and cost money to administer. Thus, they're not going to get used in routine care. And so I've been fortunate to be involved with some work funded by the National Institute of Mental Health through an R01 to Kara Lewis, who's now at Kaiser Permanente. And we've been doing systematic reviews of measures and also developing criteria for rating psychometric and pragmatic properties. And so I think this is hopefully going to be useful in driving us towards measures that are free, brief, and more pragmatic for organizations and systems to use. And certainly we've many of these criteria are actually stakeholder facing. So we've worked with community stakeholders to see, what do they find, what do they define pragmatic properties as? What does that look like for them? And what might make measures more usable? I mentioned the mechanisms work. So we're working through an AHRQ funded conference grant. That's a 3-year conference grant that's going to be conducted in collaboration with the Society for Implementation Research Collaboration, which was mentioned yesterday. This can be my commercial for CIRC. I hope you all come in September. It's a really great conference, a great community, and we're struggling to really try to benefit from the perspectives of policymakers, practitioners, be that implementation practitioners or clinicians, really practitioners broadly, and researchers. And how do we bring these folks together and have meaningful dialogue in this space? And I think that's a challenge, and it's something that obviously Allison and her colleagues are trying to do here and doing a great job of. So really applaud this effort and CIRC's effort to do that. But so CIRC has this effort to understand mechanisms of implementation strategies. What are the kinds of studies that we need to do in that area? How do we need to advance the field with respect to mechanisms? And certainly there's an opportunity for a wide range of stakeholder involvement in that. And really would welcome you to that dialogue. So we'd love it if you came to CIRC, and there are opportunities to inform that agenda if you'd like to get involved. This is just a commercial for a paper that Geeta Gopalan and Alicia Bunger and I put together. That we talked a little bit yesterday about sort of what it's like for early career researchers, in particular, to engage in community engaged work and university incentives and the like. And so this was, I think, this really was Geeta and Alicia's work with community partners and highlighting lessons learned there. And I think they were, far too often, I think we're not very honest about the challenges and opportunities associated with this work. And I think they were pretty frank about, what worked, what didn't work, what they would have changed, and how we can learn from their efforts. So would recommend you take a look at that if you get a chance. I think I'm right at time. Hopefully we have time for some questions. Feel free to contact us if you have thoughts, and eager to continue learning for y'all. Or if I'm over time, I'm happy to get off the stage. Oh.
Okay.
Thank you. Yeah, I'm just wondering if you can say a little bit more about what in the article, core competencies for assessing readiness, researcher readiness, what those are.
Yeah, so honestly, I can't recite the domains nor the competencies right now, but I'm happy to share the article as soon as I sit down and take a look at them. What I know is that we adapted a previous model of CBPR, so I think that they would be very familiar. As I was listening to Paul's yesterday, they seemed sort of familiar. So some of them are sort of, respecting historical context and being aware of that, not coming in with a an expert mentality where we're imposing our rather learning communities. But there's a whole sort of, I can't remember if it's 8 or 12 domains, and then a bunch of competencies within that. And so I think the work that they're doing now is to sort of refine that list and see, can we develop a measure that will be useful and informative, again, in university context to inform readiness.
Mm-hmm. That's great. I like the idea, Byron, of
You need a pretty picture, because that was one of my challenges. Is I knew I wouldn't be able to remember those, and we need a nice diagram of those. Sorry.
Okay, great. Who was it? Oh, hi.
Can't throw it this.
Hi, my name is Laura Kiesler. I'm the Assistant Director over our Division of Performance Improvement at the Rhode Island State Department of Children, Youth, and Families. And I really appreciate, I've been struggling with this yesterday. I really appreciate sort of the acknowledgement that public systems or organizations in and of themselves are a community to be engaged and prepared to do research on, right? So there's the person that's delivering perhaps the intervention, the social worker, the therapist, whomever. Those people are part of large organizational systems who ourselves have to be ready, right? They're living in a context of what's happening and going on in my instance in a large child welfare system that is very complex. And if the organization itself isn't ready, then then they're going to struggle even more to be ready. And so I appreciate the acknowledgement that that organization itself has to be prepared and open and engaged in how that implementation happens.
Oh, wow.
It's a little bit of a different topic. When you talked about selecting and tailoring implementation strategies and that research, are you looking at the timing as to when you're choosing which strategies within the implementation process and the different antecedents or the triggers for when you need that specific strategy, as well as the consequences of when not choosing a strategy at specific times in the implementation process?
Yeah, so it's a great question. So fundamental to how we're thinking about this is a phase model, and we're drawing upon the exploration, preparation, implementation, and sustainment model by Greg Ahrens. And so trying to think, that's actually an interesting thing in the tailoring literature, is that this notion of assessing barriers, tailoring strategies, and then seeing if it's effective might be missing, that barriers change over time. This is a complex space in which we need to be more adaptive with our strategies. And so that's certainly fundamental to the way we're thinking about the model, is can we provide sort of the tools and the structure to help people anticipate that and do that. It's one of the reasons why I'm somewhat convinced that the way we need to be thinking about testing these things as sort of generalizable processes, rather than, this strategy is going to work all the time for this barrier. Because I think it's just far too complex. There are too many moving parts. And I think a lot of our effective implementation, multifaceted strategies at this point are very dynamic and, involve things like facilitation and coaching. The challenge there is that it's not often clear what people did and how they did it and why. So we're trying to be more systematic about adapting that, tracking that rather. And in some of our work, we've been able to see like how do implementation strategies change across those phases of implementation. And hopefully we'll get, I think the second part of your question was like a little bit more like precision medicine, do we have really answers about what works when and why? And I think honestly, that's a little bit further down the road, but I hope that we're kind of setting up for that type of a science to develop.
I think we may.
Yeah, I think I
Yeah.
have one just kind of comment as we're transitioning. So as a implementation practice learner, I think some people in here, I think sometimes Byron just kind of blows my mind because it's a lot. And so I'm thinking some of the articles that you lifted up might be something we might want to consider a journal club on, that we could potentially post, and then if some of us wanted to talk about it and kind of dig into it a little bit more, I know for me that might be useful. So as we're thinking about what we want to do together going forward, these are the kind of ideas that if you could share those with us or in your evaluation, or we could think about, would be great. It's very helpful to have kind of the list of the key things though to learn more about. And so I really appreciate you bringing that to us.
Thank you, and happy to find you better reading material for your journal club.
Thank you so much, Byron.